We are live, so we can go ahead.
Okay. Good evening, everybody. Today, in the One Person, One Talk series, we have a very famous trauma surgeon, Dr. Dheenadhayalan from Coimbatore. He will be talking about aseptic non-union of the humeral fractures. Friends, Dr. Dheenadhayalan heads the trauma services at Ganga Hospital, Coimbatore. He is the past president of Tamil Nadu Orthopedic Association, past editor of Tamil Nadu Orthopedic Journal, past AO Council member, founding member of APOA Trauma Session. He is the first Indian to perform live webcast on nailing in open fractures from mutants in Switzerland. He has got many national and international presentation and publication in well-reputed and indexed journals. Welcome, Dr. Dina. I know Dr. Dheenadhayalan for many years. I had the opportunity to visit Ganga Hospital a few times and spend time with Dr. Dheenadhayalan and Dr. Rajasekaran. This was one of my first visits during a compound fracture symposium they had organized. You can see Dr. Sunil Kulkarni, Chetan Pradhan, Dr. Dheenadhayalan, and we took the rounds in the hospital with Dr. Rajasekaran, and it's a huge setup with including bone bag they have. They conduct so many operative meets. Even last month, they had conducted hand injuries and plastic surgery, virtual trauma meets they had conducted. They regularly conduct operative trauma courses. And I had the opportunity to meet him on many platforms at different occasions like TraumaCon, MOACon. Even I had gone to Coimbatore when you are the president-elect of TNOA for their conference. This is at Kakinada, WhatsAppCon, and again TraumaCon, so many things. But the one I cherish most is when he was the president last year. He had called me for the Professor T.K. Shanmuga Sundaram midterm CME that was held at Chidambaram. On that day, incidentally, it was my birthday, and we celebrated together our birthday and also visited the Chidambaram temple in the morning and did the puja with him. Welcome, Dr. Dheenadhayalan. We have an expert panel in the form of Dr. Vidisha Kulkarni from Miraj, Dr. Ramesh Babu from Chennai, and Dr. Swarnendu Samanta from Kolkata. Vidisha Kulkarni is Associate Professor and Chief of the Hand and Upper Limb Surgery Unit at the Postgraduate Institute of Swasthayog Pratishthan in Miraj. She is a very well-known electrosurgeon. She has done all the AO courses, published many papers in national and international index journals and textbooks. She has worked as faculty for almost all the trauma and electro meets like TraumaCon, NailsCon, Master Hip Course, Deformity Corrective Course, MOACon, YROC, POSAC, Trauma Conclave. Even recently, she was in Sholapur for the Solapur Trauma Meet, and she is also one of the faculty for the AO Master course. Again, we keep meeting on many platforms. This is at MOACon in Pune. This was MOACon in Mahabaleshwar. This picture has been taken about 4 years back. Recently, she was here in Sholapur for the Solapur Trauma Meet, and we had the opportunity to visit the Dr. Kashi Vishwanath temple when we had gone there for one of the midterm meet of Central Zone, along with Sunil Kulkarni and Sushruth Babalkar. Ajit Saigal, Dr. Ajit Saigal had organized our visit there. Welcome, Dr. Vidisha. Dr. Ramesh Babu, he has done MS from Kilpak Medical College and MCH from Liverpool. He is a sitting president and a Rotarian. He is the president of Rotary Club of Chennai, Gemini, and is the director and chief of orthopedic surgery at Spot Hospital, Kodambakkam in Chennai. He is currently the chairman of Center-State Relationship Committee of the Indian Orthopedic Association, and he has done a lot of work. He is the past president of the Tamil Nadu Orthopedic Association. He was the past president and secretary of Madras Orthopedic Society. He has won many medals and awards. In 2002, he won the Indo-German Orthotic Foundation's Mohandas Weller Gold Medal Award. He has also won the coveted Dr. K.P. Srivatsava Gold Medal for the best poster presentation of IOA in 2006. He has been an eminent teacher and has trained several postgraduate students in orthopedics. He has been a faculty in many state, national, and international seminars, workshops, conferences, and also has organized many CME programs, and he has several medical publications in reputed journals in orthopedics. He was the first orator of RVK oration instituted by Government Rajaji Medical College at Madurai in 2014. He has received the Best Teacher Award by Tamil Nadu Dr. MGR Medical University in Chennai. Friends, as I said, he is very active and is the chairman of the Center State Relationship Committee of IOA, which coordinates between all the states and the center. This is one of the meeting where he was chairing during the IOACon at Kolkata. Recently, just before the lockdown, we were together in one of the state conference of Telangana at Nizamabad. And 2 years back, we were there for Oasis Con in Manipal. That time, along with Dr. Vijayaraghavan and Ramesh Babu, we went to the famous Krishna temple, and you can see here near the Kanakanakindi, you can see the Lord Krishna only from a small hole in this temple. So welcome, Dr. Ramesh Babu. Friends, as I said earlier, he has been the one who is the chairman of Central State Relationship Committee, and we are all celebrating the Bone and Joint Week this week. From 1st to 8th of August, we are celebrating the Bone and Joint Week. And the Indian Orthopedic Association was formed on 4th August. And incidentally, Dr. Rajasekaran, when he was the president in 2012, he decided that we should celebrate this Bone and Joint Day as 4th of August, and a commemorative stamp and a postal cancelled stamp was also released on this occasion. And this year's theme by our President R.C. Meena is Prevention of Deformity in Degenerative Diseases. Dr. Ramesh Babu has been doing enormous, tremendous work, and we are getting so many reports from across India where the work of Bone and Joint Week is being celebrated. We have Dr. Swarnendu Samanta from Kolkata as another panelist. He is a consultant Peerless Hospital in Kolkata. His areas of interest are pelvic trauma, arthroscopy, and arthroplasty. He is associated with EVO since 1995. He is a DNB faculty. He is at present the secretary of Indian Arthroscopy Society, and almost they conduct every day one webinar. Again, I have been meeting him for the last few years regularly whenever I visit some of the conference in the northeastern region. This is he was the main person along with Indrajit Sardar for organizing the IOACon at Calcutta. Friends, we also have Dr. Ashok Sham and Neeraj Bijlani from the Ortho TV to take up the questions which some of the people who are watching on YouTube will be posting. I welcome all of you. Over to Dr. Dheenadhayalan for his presentation.
So thank you, sir. Thank you for a very good introduction. And then I thank President-elect for calling me over for this talk. Actually, when he asked me what should be the name for this, I said he only must name it. So the topic I chose was for the non-union of the humerus, which would be a aseptic non-union. But however, on this panel, we have Dr. Ramesh Babu, Swarnendu Samanta, and Vidisha Kulkarni. Actually, like Swarnendu, I wanted to invite him for this AO meeting that was supposed to be here, but unfortunately,
it was scheduled there,
unfortunately, we couldn't have it. And I cherish all the moments with Dr. Ramesh Babu because he has been, actually, when I was the president of Tamil Nadu Orthopedic Association, he has guided me very well. And then he has taken me through the entire course. And Vidisha, of course, we know her through Sunil, and of course, Sunil was very, actually, he is a great friend of mine. And then Vidisha has been like, we had a lot of interaction in a lot of AO courses, and it has been a tremendous interaction we had in those courses. I welcome you all for this. And then Ashok and Neeraj, good friends. And then, of course, they have been with this Ortho TV for a long time, and I thank you all. And then actually, I was telling them that this has been like a great boon for entire orthopedic community, that Ortho TV has done wonders for them, this especially in this Corona time. Thank you, Neeraj and Ashok. So we'll go get into this topic of aseptic non-union of humerus. And actually, this aseptic non-union of humerus, when I chose it for one reason, that this is one fracture that if it goes wrong, it can go wrong many times. And some of the times I also have seen it has gone wrong in my hands also. And when I go into problems, actually I change hands. My co-consultant will do it for me. So it would have healed by my co-consultant rather than me. So in the bargain, what I would like to tell you is that the personality of the humerus fracture is more important. And then we need to have great input into this management. We should not say that, okay, this is a non-union. This has been treated by nail, let us go for a plate. This has been treated by plate, let us go for a nail. Not like that. It is, you have to put in a lot of your mind into it, so that to get all these into a right situation and get a good success. I had a trauma service in this Ganga hospital. Actually, Ganga hospital is well known. I'm sure that everybody would know about it. And last year in 2019, overall, our team did 11,490 cases. So it's a huge number by any standards, of which humerus fractures were 1,225. If you take those 1,225, the shaft of the humerus formed 289 fractures. And among these 289 fractures, we had 28 aseptic non-unions. So that means, like in overall in this type of service, we have a lot of patients to deal with, and this has to be done extremely well. And in this scenario of such a huge number, we always go through our mentor's vision. See, like we are all with this, we are with our mentor, Dr. S Rajasekaran, great visionary. And the only motto that we have set up is, patient's interest is our interest. A patient wants it to be all right, so is our interest. So we have to make everything all right for that patient. And for that, most important is the uniformity of care. The uniformity of care comes only if we seniors share the knowledge, educate our juniors, and then make sure that everyone in the team perform the same that I do. Whatever I do, you can see the front rows. All the front row are our trauma consultants. Every trauma consultant there will do exactly the same thing that I think. And they will also think the same thing I also want to do in the same patient. And if we have to establish this, it requires a lot of skill and lot of dedication and lot of academic service. So this is what is very important in a scenario, and to deal with such a large number of patients and to get everyone into the right goal of having a good treatment and then good outcome. Everybody have to gain this same knowledge and then same set of skills to perform well. And if you take the second row, senior registrars, they will also be catching up with us, and they will also do exactly the same as the age catches by. And Ortho TV, I think, by spreading the same knowledge to everybody, and we faculty, experienced faculty in this forum, and then when we share the knowledge, I think we also would achieve the same in entire India. And I thank President-elect for getting all these into a forum. Actually, I see a lot of seminars, lot of programs going on, and it is a great service. Instead of a conference that we attend, now everything is there with a touch of a button. I think it is going to be a great boon for the young generation, and I think they will be immensely benefited out of this type of programs. Humerus shaft fractures, by far you know that If you read Campbell, first thing they tell you is that non-operative treatment works wonders. Actually, he says majority of the patients can be treated by non-operative methods. And even if AP bowing is less than 20 degrees and lateral bowing of less than 30 degrees is acceptable, and then they can, because you see shoulder is a circumduction joint, you can do a movement in every direction. And this amount of an angulation get compensated by the shoulder movements, and safely you can do a conservative management. But over a period of time, like we have moved over to an operative treatment purely because of the cumbersome nature of your cast, especially of the upper of the humerus. And also, like if you read Sarmiento et al. By functional cast bracing, they vouch that majority, almost like 95% of the patients heal with a conservative management. If that is the case, when we operate, I think we must take it to 98% of a good healing and good treatment. So that is what is important. And if you see that, if you specify what are the operative indications for a fracture shaft humerus, it is going to be an open fracture, vascular injury, radial nerve palsy after closed reduction, floating elbow, failure of closed treatment, of course, pathological fractures, or if it is associated with this brachial plexus injury. And also like polytrauma, if it is a part of a polytrauma, bilateral humeral fractures, morbid obesity, segmental fractures. And if somebody has to use crutches, if paraplegic, if somebody has to use crutches, all of them form a good operative indications for your management. Having said that, in fact, many of these fractures can be managed extremely well. And then you know that it is the plate or the intramedullary nails that are in vogue as a common practice. Sometimes, yes, if it is an open fracture, external fixation they can be used. And special times you can use Ender's nail, rush rods, or elastic nail. Pediatric patients, you can use elastic nail. So various methods, various implants are there, but by far the plate and the interlocked nails are the commonest that we use. This is a transverse fracture, and many of them might also say that, okay, let us treat with conservative management, possible. But in a scenario where you, especially in our scenario where I treat lot of fractures, it is, if you plate them well, and then many times you can forget them, many of them will heal well. So that is why it has more often the operative indication has taken over than a closed method of treatment. But somebody who is passionate about a closed method of treatment, definitely they can do it. So these are good fractures for you to treat by conservative methods. But however, when you do a good plating, that is, if you have a good contact, good compression, and if you get it into a good alignment, and if you don't do a lot of stripping, if the biology is preserved, I am sure that you are going to have a good healing. So this is what happens. You can get a good healing and they will have a very good function. See, this is all comes. You don't have to wear a plaster for 6 weeks. You don't have to come in for every week to the hospital to check whether it is angulating or not. So those advantages are there. So you can do a plate fixation and it's a safe practice and you can get away with a lot of good union. However, you must remember that when there is a communition, suppose if there is a segmental communition like this, you are going to treat not by just, you can't just strip everything and then look for all those fragments and then fix it. Now with advancements and MIPO technique that is being used, you can see that we have slided the plate and then it is all, you get into a good alignment and then it can go on to heal very well. So that is, if you preserve the entire biology, like you don't strip the tissues and you get length, rotation and alignment all right. In every long bone, this is what is important. If you get your length, rotation and alignment. If you get this and MIPO you do in humerus, it is perfectly, it will heal very well and there is no issue at all. But what is the biggest problem in humerus MIPO is the mall alignment. Many times you will get a lot of rotational mall alignment. that you need to be intraoperatively, you must be continuously be cautious of it and get the alignment all right. Then there is no issue. The alignment you can get by you visualize your greater tuberosity sulcus in the proximal region and then look for the olecranon fossa down below and make sure that in a right AP view, both of the sulcus would be seen and olecranon will be good round in shape. And if you can get that into a good in a AP situation, then that means your rotation, you have got it in control. And MIPO will do wonders for you if in all these segmental combinations. Sometimes the combination like this, a long segment, here again it is almost extending up to your greater tuberosity. And then you can also do a nailing. And again, when you do a nailing without much distraction and you get into a good compression here again, and then you get the alignment all right, then it will also go on to have a good healing and they will also get a good function. As long as your technique is good, then there is no issue at all. And again, you see, this is another fracture where you have a long segment of comminution and then you do a nailing and they get into a good function at later on after a good healing. So consistently, if your technique is very good and if you have got all these points correct, then nearly 95 to 98% of the times, you will end up with a good healing, good function. What I would like to say is the best results are obtained if the implant and technique chosen is based on fracture personality. Do not go by saying that I will do only plating, I will do only nailing. Choose according to the fracture pattern. And if you choose according to the fracture pattern, and I am sure that humerus is one bone which heals extremely very well. This is a 24-year-old lady. And then you see like nailing is a long segment combination. You can choose nailing as a good option. And once you choose, you also need to look at, is it an antegrade nail that is important or a retrograde nail that will be good enough? See, this is more extending towards the distal portion. If you want to have a good purchase, if you start an entry point on the distal portion and gain it, you will have a large segment to hold and your stability would be good enough. And also like when you start from the distal side and go proximally, in the proximal side, you have got a better medullary canal. So you have a wider medullary canal. And when you are going in, so the distal fractures are less common. On the contrary, if you choose an antegrade and then you have a problem distally, suppose sometimes you jam it, and then you end up having some sort of an issue like a distal fracture, then you are ending up with a fracture like that. And then you see like now what they have chosen is they tried to put another pin through that nail and then try to hold on with a small segment. Actually, last week, I think one of our speaker from abroad, like I think he's Shiv Shankar's best friend, and he has Halder, I think, so Subhash Halder. So he was, yeah, he even with a small segment like this, a retrograde nail he has done his nail, and then he has got a very good result. So you must have a secondary plan. Something happens like this, you must have a secondary plan of management during the surgery itself. So always when you have a distal fracture, if you want to choose a nail, it is always preferable to go in for a retrograde than an antegrade. And that is what is important. So here you can see it has broken, and then there was a light was let off like that. And then you have to think that it is a question of waiting time, and then now it has ended up with a non-union. And once you get into this type of a non-union, and you need to get everything right, you have to do all these, like you have to get your alignment correct, you have to enhance your biology with bone graft, and then get a right implant and get a good stability. And if you do that, at this scenario also, it will go on to heal well. So what is important is you must have a circumferential contact of the bone ends, and then you get your alignment and biology correct, and nearly it will go on to heal well, and they will have a good function. So there is no doubt about it. Actually, humerus is a bone. If you do the surgery right, it will go on to heal well. So you must never ever think that it is the nail or the plate that is going to work for you. It is the technique that is going to work for you. So Whenever you do this surgery, always anticipate something. You must have a plan B. So during the surgery itself, you must have a plan B. Suppose if something happens during surgery, can you change over to something else? See, this is a fracture. It's a mid-shaft fracture. So lady, and it was we measured the intramedullary rod diameter, and it was reasonably okay for me to nail. And then I thought that either I can go by antegrade or retrograde because it was more like a mid-shaft fracture. I also tried to do this nailing and it was going on all right. But you see, suddenly at the end, again it breaks like this. It is exactly what the other surgeon got. I also got the same set of scenario. But it is these type of scenarios that you must be prepared to change. These are the scenarios you must get your more energy at this level, and you must energize yourself to do one more surgery at this stage. So we just repositioned him, and then we see, you can see that it has burst open, and then you can see the extent of your distal fracture, and it is all the way down. And then when it is happening like this, then we have to have a plan B. So this is what I did at that stage. So we had to choose a extra articular plate as well as index rod to hold on to the column, and then the other column also held, and then everything was held in position, and then it goes on to heal without any issues. So I think you need to think in a scenario what is the best, and you do it right. And every case, if you do it right, and majority of the times it will go on to heal well. So if you look at the literature, if you look at the wide literature, the non-union rate is 5 to 10% in humerus. Whereas if you take a femur, it even extends up to 33%. In few of the literature, it extends to 33%. Whereas in a humerus, you can see the non-union rates are much lower than any other situations. But what you need to be worried or looking at is the communition, a segmental fractures, or a high velocity injuries and open fractures. These are the patient personality that comes with which you have to be worried where they can end up with a non-union. Whereas from your point of view, if you do the right fixation, lot of the times they will all heal well. So I would like to stress the point that your fixation is the one that is going to matter in all these fractures. So improper or inadequate fixation can lead you to trouble, can lead you to non-unions. Often the non-union is due to problems in surgical technique. And that's why you need to correctly do it in every case. And if it is done, then there is no issue at all. What I also would like to tell is good results are frequently only equal or slightly better than the conservative treatment. Whereas you must remember that poor results after surgery are incomparably worse than the conservative treatment. So if we keep this into our dictum, then we will do everything in the right. But before we embark on a non-union treatment, you need to realize what type of deformity the patient has got. You need to look at any rotational deformity in the non-union scenario is there. Is there a valgus varus, or if there is a posterior or anterior bowing is there. And suppose if there was an open fracture before and then they had done some flaps, abdominal flap or some flaps were used. And then look at where is your incision is going to be. Look at the condition of the soft tissue envelope. And every case, do not forget a neurovascular examination. There may be some sort of mild neuropraxia that would have happened. And then if you are not examined, and then secondarily, if there is any change that is there, you need to have a basic exam so that after the surgery, you will know what has changed. And of course, any non-unions, you have to look for signs of infection. That is, for every non-union, you must make sure, you must divide them as infective or aseptic. And for that, you need to look at your all the parameters, like any sort of previous sort of infection was there, or previous sort of redness, previous history of fever, all those things you need to look at. A case required laboratory tests, and also like look at all the radiological adequate imaging and see that anything is like if there was any pin tract infection was there before or not. If plate is there, look at all around the plate and see all around the screws where any lysis is around there. Everything you need to look at and make sure that there is no sepsis involved. And then, of course, any patient who has got persistent pain beyond the duration of their time limit for healing, if there is a progressive deformity, every X-ray that you check, there is a progressive deformity. And if there is no radiographic evidence towards healing, and you start seeing the movements of the implants, I think there is no point in waiting in these patients. You need to intervene and always rule out the infection. And if you rule out the infection and make sure that you are treating an infection or aseptic. But many times, sometimes you might also feel that it is aseptic. So you go into the theater and moment you open it, sometimes you may see that lot of reaction around the plate. Sometimes there will be fluid collection around the plate. And you might wonder whether there is infection or not. In those instances, if you have any doubt in those instances, then you must wait. You must stage it and treat it as infection rather than as a aseptic non-union. So this is what is important. So you can see that here, there was one of the fracture. Moment we opened, there was a fracture. Infection was there, like slimy fluid was there, more looking like an infection. So what I did was, before removing the implant, I put an X-fix so that I maintain that position, everything. I don't change everything because it is a so that you don't have to worry about fixation later, alignment later. So with the plate, have your external fixator in the beginning, remove the plate, and then make sure that you debride the area very well. And then you have to hang on with the external fixator if it is in right position and see if there is a radiographic evidence of healing with every X-ray that you take, every 6 weeks we take. And then if there is a progressive healing, you wait, and then it goes on to heal well. So this is one of the things that you need to look at. Maybe it was not a completely a sepsis, but it could have been settled down. So this went on to heal well. And another case where you can see, like, this is also where there was a suspicion. So we went on to do an external fixator. You correct the deformity and hold it on in position, and then it will go on to heal well. So what I mean to say is, as long as you have your alignment all right, you have the contact, and you also have the compression, and you do not disturb lot of things, and biology is not altered much. And I think all of them will go on to have a good correction and good healing and outcome. So this is a fracture where there is a medial comminution. Often you see that when there is a medial comminution like this, so this is a compression zone, and then you want to do a plating. And then you can see like this also, you can argue whether you want to do a conservative or an operative treatment. But however, so here we chose this, and then you can see that a lot of arguments can go on, like these 4 months, why it has not healed. Somebody asked, then you can put in all your arguments saying that there was an opposite cortex comminution, there was an opposite cortex that was not in contact. Everything can be given. So in these scenarios, when there is a medial comminution, it would have been better. Sometimes a humerus plating also can be done on the medial side. So if you have done on the medial side, opposite cortex would be all right. It will be in continuity. And if you compress the opposite, if you attend the AO basic course, you know that once you put 2 screws and then take out and then bend the plate little bit at the fracture side, and then go back again to put the plate, you will get an opposite cortex into a nice compression. So this type of techniques, when you do and hold it on the position, if you have done the medial plate, well, it could have been gone on to heal. So we don't know it, but that is the way you need to look at in every case. Where is the fracture? Where is the comminution? Depending upon the comminution, you can put your plate, and then you can choose nail. Suppose if there is a comminution, many times it is the nail that works better than your plate. So you have to choose it according to your right personality, and also your experience counts. So 4 months, this has happened. So at 4 months, should you wait or should you go on? So you might say that there is some amount of callus happening. So we can wait here and things like that you can look at. But however, what you must understand is whenever you see a gap, or if there is an instability that can be seen, or if because it is a 4 months and then in upper limb you expect it to have already, you would have had some nice bridging callus. So there is a gap with possible non-union. And if you see any implant movement and any alignment problems, you should not wait at all. So in this case, because there is no union that is happening, it is better to intervene at this stage. Do not waste another 2 months and see and then go in for it. Often, sometimes there are instances where You might have asked for a healing, or that is, a patient would not have agreed for your treatment at that stage. He would have come after 2 months. Many times it would have healed. That is, you never know all these things. But scientifically, if you see that there is no healing, at least in 2 consecutive X-rays, you must think of intervention and you must get your non-union treatment going on. So this is a patient where there was an initial conservative treatment, already 7 weeks over. So there is, you can see that it's abnormal mobility, everything was there, and then there was no bridging callus that is seen. So there is no point in waiting. You get into your scenario and then you do a good compression and plating, and then you get into all the parameters that I said to be all right, and then it will go on to heal well with a good outcome. So it completely healed and they will all get a good outcome. So this is shaft humerus. Shoulder and elbow movements are going to be all right, so you don't have to be worried about it. So if it is only question of healing. If you heal well, if they heal all of them, and the outcome is going to be nice. Any of these fractures, your diagnosis or intraoperative vigil is not correct. Sometimes, sometimes you may not have got it right, but somehow if you put plaster post-operatively, see, like lot of, I see a lot of, few of my colleagues would say that, no, I will never put a cast after fixation. Those terms are a little vague, but thing is, if you ever think in the intraoperatively you had some problems, some issues, and then you don't want to have any other problem with the union, post-operatively there is no worry at all in putting a cast for some time. In case, especially in a distal level, if there is a distal humerus and you have some sort of a vague idea that your fixation was not completely all right, then you must put in a plaster. So if you do that, it will go on to heal also. So you have to be weighing everything. It is not only your pre-op diagnosis, it is not only your intraoperative treatment, actually it is post-operative care also is extremely important. Post-operatively, like application of cast also is important in addition to your surgery. So all this you must take into your good account. So this is a 51-year-old lady. I am sure that all the faculty here agree that they will treat with either nail or a plate and they get a good outcome. I am sure because 95 to 98% of the times it can heal well. But however, you see that this is a fixation that has been done. But moment you look at it, suppose if you have a fracture line that is seen, so you must take it that you have put it in distraction. Humerus is one bone that doesn't tolerate a distraction. Either you put nail in distraction or you put plate in distraction. Often it ends up with a non-union. So it is important. And also you see the alignment. You see that the alignment is also a little bit into valgus. So when you have an alignment issue and also distraction, so you are also looking at the scenario of a failure. And also when there is a plate that is eccentrically placed, suppose if you have a plate that is eccentrically placed, and then you have 4 screws going, that means it is like you have a big rock where, no, everybody when they break the rock, what they do is they put multiple holes and put those blasting things, and then once they blast it, it breaks into nice shape. So like that, what happens is when you put 4 screws, like 4 holes like that, and start with the cortex on one side and go in a line like that, then majority of the times that cortex along with that line will break. So that can happen in any time. So what happens is it can result in a secondary fracture as well. So this is how it happens. So you can see like this was a fracture that could have missed also. Like we don't know whether there was a small extension of a line, or was it the same thing that I was telling that there could be a secondary fracture that could have happened because multiple drill holes that we make because of the eccentric placement. So as time passes by, you can see that that fracture line, and then it gives way and the entire plate along with the fragment comes off. So when it comes off like that, then it is going to end up with a non-union, and then we need to again revise it. And the revision is always the same. So revision is you have to have a good contact and compression. You have to have a good alignment, enhance the biology with bone graft. And if this dictum is followed, I don't think any one of you will have any issue with management of a non-union, and it will go on to heal well. And here you can see it has gone on to heal well. And then this has went on to have a good outcome. So once you know this is the dictum that you need to follow in a non-union scenario. And every case that you do, you follow the same order. And this is the patient. Again, you see it was in distraction, went on to have a non-union. And this is the 40-year-old male. And this is 16 months after initial surgery. But you see this nailing, if you take, is not only in distraction, they applied a short nail. A lot of things you can tell. So superior also, it was not sunk in. So rotator cuff also will be in trouble. Everything this. So you need to do that right. If initial surgery was right, then there was a possibility that it could have gone on to heal. So it is again a technical issue that has happened. And again, you see this is the same thing. It is you have to get the contact, compression, alignment, and biology, stability. All these things, if you get it right, and then it will again go on to heal well. And I've stressed it many times now that what has to be done. So it is remember CAPS. It is contact and compression, alignment, enhance the biology with bone graft, and stability. So you have to give a correct stability. So you have to give an adequate stability. You have to give, because it is an open reduction that you are going to give, it is like you have to give a rigid fixation. And if you give a rigid fixation with good compression and alignment, it will all heal. So this is again a 44-year-old lady. You can see that what happens here. It is an immediate post-op. See, when you look at it, it is a good X-ray. It has been fixed well. I don't see major issue except that in a lateral view, there may be a small spike that is seen. Some sort of mild angulation might have happened. Otherwise, this good fixation. But something you need to look at in a fracture situation when you are doing this plate fixation, amount of stripping. Sometimes you may have stripped the soft tissue a lot, and that may be the cause of a problem. So when you are opening it up, you must think that you have to preserve a lot of biology. Do not strip the soft tissues. And if you have done that, probably this would have gone on to heal well also. But here, this ends up with a non-union, and that was changed into a nail. So that in between X-ray I don't have. So this is the one that has been done next. So when you see this nail later, and then you can see again it is in distraction. When it is in distraction, and also you see it is not sunk in, because you see that also will cause rotator cuff problems. And then because it is not adequately compressed, then it may again end up with a non-union like this. So now you see it is non-union, and also like because of the implant movement, distally you can see that actually the screws are almost cutting out, and then there is a possibility that you can break the distal portion as well. So because of this, now you have to look at a non-union scenario and also possibility of preventing a fracture at the distal level. So when you are looking at this scenario, then we have to have a fixation where you are also taking care of the distal segment and also the proximal segment. So this is one of the fixation that I have done, like you have to use a column fixation as well. And then the ender spin that you see in between is actually it was going on the other column, but the final X-ray, then it got migrated. So that is what has happened. So you can see it went on to heal well, and then they get a good function. See here, it is absolutely like patient will be thrilled when they see this type of unit, because they have gone through the agony for nearly 4 years. And then when you go through it, and then you do exactly the same thing that I told. It is contact and compression, alignment, biology, and stability. If you get all these parameters correct, then there should not be any issue about your healing. So let us look at this scenario. It is a 36-year-old lady. If you see this plate fixation, you can see that probably there was a rotation that has happened at the time of your fixation. So you can see that moment you look at it, so the fracture configuration doesn't match each other. And in that AP view, you can see that there is proximally the fragment is little offset. And when you have this, I think at the time of your surgery, there was little offset that has happened, or mild rotation that has happened. So your fracture didn't match each other. And then it also shows some distraction. And when it has got a distraction, then it is going to end up with the issue of a non-union. So that is why in every case that you operate, when it is in the fresh fracture situations, whatever I said, you follow, it is going to be all right. So this statement, I'm repeating it so many times so that it gets stressed into everybody's mind. And you see that they have revised into another plate. So when they revised it into another plate, again, you see, you don't see much of compression. You don't see the compression here. When you don't see the compression again, it is going to be an issue. Many times you may be lucky, but it is not so, because you can see it can end up with non-union. So here again, you see it has ended up with non-union, persistent non-union. And then what I do again is go in. But in this, immediately you remember when you open the fracture site, in a non-union scenario, you are ending up with more stripping than what you have done in a fresh fracture. And then when you are doing it, see, you have to realize what is all dead bone, what is all not a, say like non-vital bones. So those who are non-viable. So best way to see is try to nibble the bone. At the end of the bone, when you nibble it, sometimes if it is like a wood crackling, sometimes when you break it, it will give you a crackling sound like breaking a stick. When that happens, it is all dead bone. But sometimes you will struggle to break it, struggle to nibble it. Those are all good bones. So you try to do that every time when you do the surgery, you will understand that. So you try to nibble that end and see, and then when you get a crackling sound, that means it is all dead bone. So it will easily come off. And then you have to see that the resection that you are deciding. So at the time of your surgery, you might think, okay, let us shorten it and then do. Because humerus bone, there is no harm. You can shorten a little bit of bone up. There is reports that up to 4, if you read, there is a good article by Ring and Jesse Jupiter where they have said that up to 4 centimeters of humerus can be shortened without much issues. So you have to know that. So you try to nibble it and then keep on scraping it and see where exactly is the bone that is viable. But when you are doing that, make sure that distally there is a good segment of bone for you to fix it. You should not be too aggressive and think that, okay, I can nibble it off so that it will get a viable end, and then you end up with a scenario where there is a distal segment is too tiny. Then you have to have a different fixation like extra articular distal humerus plate you will need, or sometimes you may have to go through the columns by Ender's nail and then get it sorted out, and then you can also use a derotation plate in addition to Ender's nail. So these are the techniques that you need to remember when you go more distal. When you do that, again, it will all heal. So again, make sure that you nibble the bone that are non-viable, and then you can adequately shorten it and then get a compression, and then it will go on to heal. See, like compression means, see, you can see the hole here above. These are all used for Muller's device. So I will show you in the next slide also. So Muller's compression device, that is a very good device you have to use in all these fractures. So this is a 58-year-old lady, and you can see this has been fixed and then looks reasonably a good fixation. The moment you look at the X-ray, you would not say it is worrisome at all. But however, some of them might say that the 8 cortical purchases are needed on either side. But optimally, even 6 cortical purchase is optimal also. But if you want to keep it as a great standard for you, 8 cortical purchase is always the right type of fixation that you would do. And then here you can see that it has been fixed. I think it is a reasonably a good fixation. But however, the history was that at 3 weeks, patient again fell down. So once they fall down, again you see there is another fracture, like a peri-implant fracture that has happened. And when there is a peri-implant fracture like this, now you have an extension of the fracture. But however, the question was how exactly to go ahead and fix it. So you can think of a nailing in this scenario also. You can think of a replating also. So because you have to change this plate, because you are already opening it, and if you get a good plate fixation, again, it is always a reasonably a good fixation. But however, here they chose for a another plate, additional plate. But you see, it is a, when you put two plates, especially in a fresh fracture scenarios, and then you don't get you a good compression and then contact, then again it is going to be a problem because you are violating the biology. You are increasing the biological insult in this patient. When you increase the biological insult in this patient, and then it is also, now it is nearly around 3 to 4 weeks only, then again one more stripping that has been done, and then it goes on to have a non-union. And then when the non-union is there, and this has again been revised into, a third revision was done with the plate. But you have to be beware that because the patient had a peri-implant fracture before, and again you are coming back to similar type of a fixation. And this is also going to be because she was some 56-year-old or 58-year-old. I think it will also have an osteoporosis at this stage. So you are going to have an issue of, again, they can have a peri-implant fracture. Or if you are adequately compressed, if you have used a good compression device, this can also go on to heal well at this stage. But unfortunately, with this fixation, it has not gone on well. So you can see that again it gave way. So it is a repeat after repeat after repeat failures of plate fixation that has happened here. And at this stage, what is the best solution that you might think? If I were to be here again, because I'm opening it here, I would do a good plate fixation with all the components that I told. It will go on to heal. But however, the surgeon chose a nail. So it looks all right. Here again, you see like they have tried to bring the fragment ends together. And then, but unfortunately, there was a lot of jugglery that was going on with wire fixation and things like that they have done. So it is going to be more and more stripping that would have happened at this stage. But here again, you look, all the cortex that is there are becoming thinned out. It is all looking friable ends. And then it may be some callus formation that would have been there and so sort of a situation that was there like that. But however, if you think it is a reasonably a good nailing, we will take it as a good nailing. But however, a nailing that is done without a compression also here, but a lot of nails have come where you can also put a nut on the top and then try to compress it. It will give an adequate compression at the fracture site. And here, so this nailing has been done, but for a period of time, it has not healed yet. Patient has got severe pain. And then it is a gradual loosening of the distal screws are happening. And then it has been 7 years that has passed with all these multiple procedures that has taken place. And that when you get into a scenario like this, what sort of revision that you need to do? And that is the same revision that I have been suggesting to you. So it is exactly the same. It is take out all the implants, get into the fracture site, remove all the dead bones, all the non-vital tissues, adequately shorten it, and then make into a good compression, good contact, and then get your biology all right with adequate bone. Biology all right, I keep repeatedly telling because bone grafting alone is not. Sometimes you just pack bone graft outside, it may not work. But you need to do an intramedullary bone graft. See, where is it required? You need to have everywhere. You need to have your, so you need to put in your bone graft. You can take the tricortical bone graft and put it into the medulla, or you can choose an allograft and put it into the medulla. If it is a wide canal, you can put it into the medulla. And then you must decorticate. You must decorticate the non-union site. So where you have already fixed after fixation, you must decorticate it. So the terms called shingling and osteoperiosteal petaling. These are the two words that must come into your mind in every non-union that you do. So you decorticate the area so that you see like lot of bleeding surface on the bone. So it is like that. Skin graft, if you want to take, you must have a good skin or good granulation tissue that is bleeding, and then you just have to put your skin, it will take. Like that, if you want your bone grafts to take very well, underneath bone must be bleeding, on surface must be bleeding. You decorticate it nicely. Once you decorticate it, if it is bleeding well and you put bone graft all around and also intramedullary graft, then that is what is a good bone grafting. And once you have your intramedullary bone graft and then compress it, then it gives you a good area where already you have got your bone graft where exactly it is required, and then you do all the necessary other parameters that I told for all these fractures. Remember this mnemonic, CAPS. CAPS means, C means contact and compression. They go together. It is just not a contact. If you physically you put them into contact, it is not in contact. It is just that your vision, it shows it is in contact, but it won't be in compression. If you want to achieve a compression, then you need to have an additional instrumentation for compression. You must get a good compression. A means alignment. You have to have a good alignment. That is AP and laterally you must have a good alignment. And then B is biology. That means you get your bone graft and then you enhance the biology at that level. S means stability. You have to give a good stability. If you remember this mnemonic and every case you do that, you get this correct, and then it will go on to heal well. So after 7 years of this, and then this go on to heal, complete healing, and then patient is most happiest after this surgery. So remember this. This is not that I only do it in my team. Every member of my team do the same thing, and everyone get the same result. So if you all do this, I think in whole India, every one of you will get the same result that every senior would achieve in this case. So I think there is no doubt about it that if you all do this, there won't be an issue. Question of shortening and bone fixation. Lot of the times I already told the meaning of shortening and fixation. Humerus and forearm, these two areas, generally it accepts a lot of shortening. That we do lot of replants and then we do lot of open injuries, and we have done lot of patients with shortening and fixation. Moment you do a shortening, it means your viable bone ends are coming together. Once the viable bone ends are coming together and you do the same compression and fixation, then it will go on to heal. So this is somewhere around nearly, this was, if I measure, it was 6 centimeters. But however, I tried to shorten it here. And then when I shortened it and then do the same things, then it go on to heal well. And this is the patient. So this was an open fracture before, and then I had to shorten it. And then you see like he gets into a good function. It is, you are getting into a final result. That is union and function is your final. If the patients are needing for lengthening later, you can do lengthening. But upper limbs, they never ever come back to you for lengthening procedures. Whereas in lower limbs, they will come back to you for your lengthening procedures, not in upper limbs. Especially in our scenario where the poverty levels and then the socio-economic levels are of poor status and all. See, they want immediate function. They want healing. If you give that, they will be very, very happy about it. Bring the viable bone ends together and do everything, contact, compression, alignment, biology, and stability. Then they will have a good function, and then they will have everything that is required for them. And when you are doing this non-union surgeries, you also look at the medullary canal. So when you have the medullary, suppose in this case, you see this a failed one, and then it comes to you. So initial plate, then the nail, and then the non-union. When that scenario is coming to you, look at the medulla. See here, the medulla seems to be reasonably all right. So it is just that at that level, so it may be around 8 size nail maybe, or 8 or 9 size nail. So that means that the medullary canal diameter is an optimal diameter. And then when you revise it, you remove it. And then, so it is, see, like when you are assessing this non-union also, you will see, look, where is the deformity? How is this? The nail is broken, means how are you going to remove this? And then if it is atrophic, how do you enhance your biology at that level? Gap means how do you compress? If it is an instability pattern, how can the instability be sorted out? All these you have to diagnose beforehand and then sort. Here you can see that the broken tip can be removed. The broken tip can be removed by using Dr. Shivshankar's reverse cutting threaded extractor. Or in fact, many times it will be so loose that you can also try to pluck it out by your artery forceps and things like that. So we have those instruments where you can put in your instrument and then pluck it out. So you have to have those and then remove it. When you are removing it, you see a lot of muck comes up. There is see like lot of blackish material, blackish tissues, and all of you would have experienced this. And then lot of fluid will come out along with this. And then when you have it, then you may also think is it infected, and question mark will come. But often they are all not infected. Suppose if it is infected, it will be completely be different. All the tissues, everything will show in a different color. It will be totally be pale, and then every layer would be different. But when it is only color change, and only little fluid that comes, it will not, it may not be. But however, you can send it for culture sensitivity. But often you must remember that if you get a good stability, and then even if it comes out later on with sort of grown some bacteria, because you are given stability and then follow it up with antibiotics, often they will all heal well. So you don't have to be worried in that scenario. You have to fix it up, and then you can see that when we fix it, so you need to have a copious amount of bone grafts. When you have this, you can put intramedullary grafts, and then you can also uh, all around decorticate and then nicely pack bone grafts all around it, then it will heal. And also when you are doing all the non-union surgeries, you have to take care of the radial nerve, and then that dissection must be good enough, and then always make sure that plate is placed underneath, and then you make a mention in the notes. This is one of the important thing I keep telling all my colleagues, that they have to make a notes of where the radial nerve exactly lies. Because when they open again, sometimes if they have to open it again for another non-union or something scenario that happens, so you struggle, you will find it extremely difficult to know it. Many times when you are doing these non-union surgeries, often you can transpose the radial nerve anteriorly and then put a plate on top. Because sometimes these non-unions will be more closer to the radial nerve, best is to transpose it anteriorly. So if it is very close, and then you slowly dissect the radial nerve and put it anterior to the fracture site, and then get the entire bone outside, and then now the radial nerve will be completely be anterior. And then you have to make a mention in the notes that the radial nerve is no longer on the posterior side, it is anterior to the fracture site. So this is important thing. So every case of humerus plating that we do, we have to write where exactly the radial nerve that lies in there. And once you do this surgery, and then you can see that what I have marked is the hole that has used Muller's device would be fitting in there. It is, and then you compress it, and then it goes on to have a good healing. It is at 8 months, and then they get a good function. So all the non-unions, I'm giving you an example after example. So we have also done few of them with nails, but I'm telling you the best scenario here, and then you can get that into a good position, and then fixation, and then you do it. Sometimes the medullary canal will be too wide. See here, the nail was there. Previous nail at least was compact within the canal, but here you can see there is a lot of space between the nail and the uh, bone. So here, when there's a wide medullary canal like this, sometimes I also use a strut like this. So you can use a strut graft, and then once you use the strut graft and then fix it, then it will go on to heal. Because when the strut, what does is, when you put a strut, immediately it brings your bone into an alignment. It will give both AP and lateral alignment. You immediately get it, and then this is the Muller's compression device, and then you can use it in all cases of non-union. I use Muller's compression device, and then I achieve a lot of compression that is regular. Not a lot means not keep on tightening it. You will know by experience, you will know when to stop it. If you keep on doing it, your instruments will go off. You will lose the instrument. So you have to know when to stop that also. Adequate compression, you keep seeing it. Generally, if the K wires that are positioned there, they're all meant for getting alignment. So when I use I will put K wires in multiple areas so that I get it aligned well. And then I always concentrate on alignment in both AP and lateral. And also, like when I am compressing, I know that if the K wire has moved from this place to this place, at least 5 millimeter it has moved, and then I stop. So once that is done, then I go on to, you can see that it goes on to heal. So this is how it is. So this was a fracture where there is a gap, and then it is actually this patient, because he thought that it won't heal. Many of them have said it won't heal, and then he actually forgot about it. And then suddenly, after a few years, he has come with, because there was a lot of pain. And when you develop pain, then we said that it is because it's a wide canal, osteoporosis has not used it for 10 years. The best way to go ahead is put in a nail and also augment it. And then when we did this, nail with plate augmentation actually works wonders. Whenever you possible, this is also one of the method you can choose. Sometimes you can choose Ender's nail with augmentation plate. That is also one of the best method you can think of in a non-union scenario in the humerus. So once you do this nail with augmentation, plate and bone graft, again it heals well. So suppose if somebody has got a non-union of long duration, so they would have got a deformity, and especially in the distal places where you have a deformity like this, and then you can see that the deformity with the fracture segment, not only at the fracture side, but also on the distal plate side also, because of the long standing non-union side, they show a little bit of uh, implant movement and then the failure at the distal site, and then they end up with a crooked deformity like this. The best way for you to go ahead would be like once you debride every area that is required, and then you see that all the non-union site is curated off at the place, and then best of the method is have intramedullary curate and then nibble the bone ends, get it into a close this thing. Not necessarily that you have to use locking plate every time. The regular conventional plates with a good compression also is good enough if the bone stock is good. So locking plate is majority of the times it is for an osteoporosis. These type of plates also work wonder, and it has worked for me for many years. So only in osteoporosis you have to use a locking plate. And here again you see what I did was, you can see the ender spins are going here. See, this is where there was a previous implant movement that has taken place, and it has actually corroded or eroded the entire surface of the bone. So we had to see these two enders are going through the column. So when you get the ender spins through the column and then put into this plate as a derotation plate, and that will also make you into a good healing, and they will all end up with a nice healing, and then they will have a good function. So you don't have to be, what is important is whatever the parameters like contact and compression, alignment, biology, and stability. Get it in every case, get it right. If you get it right, then that is the way to go about it. So one of the things that you must notice in all these non-unions is when they come very late for you, there will be, because the circumduction movement that is taking place, rotational movement that is taking place, and because of the movement of this plate around these bones, there will be, because constant new bone formation and absorption, constant new bone formation and absorption that is taking place, there will be a ballooning effect on around the plate. So you can see that there is a new bone formation all around the plate, and then you can see the excrescence. And if you overall you look, there will be entire plate surface would be it would have gone on to some sort of erosion. So it is important to realize where exactly is the medullary cavity. So once when you start debriding it, you have to look at where exactly is the medullary cavity. So for that, you start with 2.4, 2.5 drill bit, then go on to 3.2 drill bit, and then go on to 4.5 drill bit, then go on to intramedullary reaming. Because from the fracture site, you do that. Then only you will get into a fair idea of what exactly is your intramedullary area, and then how much of cortex is eroded, and all those will be known. And then when you do this, if your plate is sitting somewhere on this type of excrescence, then your alignment will go wrong. So you need to slowly remove all these excrescence completely off. You must reach the normal bone. At the end, you must go on to the normal bone. And when you have the normal bone seen completely, so you will have to extend your incision distally also, proximally also, and then go on to the normal bone. From there, you look at the surface, and then your plate positioning, everything will be from the normal surface on the proximal and distal side. If you ever just think of putting your plate, bend it and then keep on top of it like that and all if you put, then again you will end up with a malalignment scenario. So here you must correctly localize your medullary cavity and use some of the strut graft or sometimes the ender's nail you can use in these type of difficult cases to get your alignment. Moment you get your canal aligned properly, automatically your alignment comes into position, and then you have to think of getting other parameters correct and then plating. So here I went ahead initially because there was a lot of debridement I had to do. I wanted to wait for 1 week and then I wanted to come back later. And then I went on to do this plate and then I got a good function. So this is what is very important. And whenever you get all these scenarios, so these are the methods. It is an intramedullary positioning, intramedullary alignment that you need to get, and extramedullary plating that you are going to do with good contact and compression, and then it generally heals well. And then suppose you see like when you get a non-union, you can still go ahead to use a nail also in these scenarios to get into, but you must achieve a compression. If you achieve a compression and then good bone graft all around, you can still go get a good healing with the nail also. But here you see that this is the plate and then this is the first non-union that has happened. And when at that stage, you can see that again they have put another plate here. It is a longer plate that they have used because you can see distally the plate has eroded over it. And then because of that, they have put a longer plate. And then once the longer plate is used, over a period of time, you see the same scenario is coming back again because all of the times because of the elbow movements is happening and then majority of the stress is going at the distal fracture site areas and then there will be some sort of implant loosening that is taking place at the distal end. So here you can see that there is again same mechanism is happening and then distally again there is a failure that is going to happen and this is what happens. And then when they happen, so again they put another plate on top of it, the dual plate method they have used. And at the end of the dual plate again, it went on to heal well. So this is the sequence that has ended up with. So when you get like this, so it is like, it is four times it has been plated and 4 times again there was a lot of stripping of this happened. And it is a scary scenario because now you have got with only a small segment of bone that is left over for you to fix. And when you have this, there is no option, but you have to go ahead and fix it. So because these are, you cannot say that I will do elbow replacement and things like that because the canal also you can't find it very well. Long segment you can't get a long sort of implant where you can go all the way up to the proximal humor, or you will have to shorten the entire bone and then think of a like a modular prosthesis like Zimmer type where you get into this thing, or tumor prosthesis like that and all you'll have to look at. But here there is a good segment still that is possible. See distally, like last week's speaker when he said, Subhash Alder said, if there is a good segment distally, you have to use that and then get it fixed. So if you fix that, probably still it is a possibility that you can get into a good function in this patient. So we did CT, but nothing we could evaluate by that. So anyway, it was most often it was intraoperatively that we can evaluate better. And when we opened it, we have nicely debrided whatever that is required. This is actually 6 years after all these sequence that has happened. At that stage, you see like the column also I had to reconstruct. You can see here, the entire column on the medial side, there was no bone. So I had to reconstruct the medial column. I used the strut to reconstruct the medial column. And then I have to, because one of the technique I choose is like, this is an excellent technique. Whenever you have, when you want your alignment to be done well, ender spin works wonders in these situations. So you get it from the distally, you have your alignment done for the distal fragment, and then you have, see I have passed the ender spin through one of the column, and then the other column I held it with the extra articular plate. And also it may not be sufficient, so I had to use the additional plate on the other side also. And then I have used bone grafts. And in addition, I also compress in all these patients when it is required. So this is one of the this is a graft that is there. So all this when it is done, and this is the plate you see, like to get a distal segment into a good fixation. In addition to your ender spin, so ender spin just is one probably a centimeter of purchase it may give, but when you have this type of 3 screws that is coming through this plate, and then it is having a additional purchase here, so you are getting a good purchase both in both directions. So it is AP as well as mediolateral in both direction. Your stress levels are going to decrease, and then patient can continue to do elbow movements, and then you will retain the elbow movements, and then all the parameters, other parameters that I did, you do it, and then once it is completely done, see you can go on, it can go on to heal well, and then it will give you a good function. So you can see that elbow movements also has come back, and then it has gone on to heal well, and then this is the way you have to do it. So I have all the aseptic non-unions that you get. This is the best method, and if you can replicate it, I can vouch it for you that 99% of the times you will get into a right scenario. You will get into a good outcome and function. So remember this, all the assessment in non-unions are done based on stability, contact, alignment, and biology. Check whether you have given a stability or not. Or when you are diagnosing it, check whether they have given a stability. What is missing in those? So you have to see that. And then contact means just not your physical contact, but it must be associated with compression. And both AP and lateral, you must give a good alignment, and then enhance the biology in these scenarios. And all the solution is to get all this correct. So it is not that it is not only you are seeing the assessment, but it is the solution is also to get everything in correct in these patients. So, but that you have to do all these things. So you have to have intramedullary reaming. So you get your medulla correct. You have to look for the medulla, and then get to open the medullary cavity. And then once you get the medullary cavity opened both proximally and distally, you can get your alignment sorted out by either your intramedullary graft, tricortical graft, or your regular, whatever the grafts that you have taken, put it between the two ends, and then you bring the fragments together. Majority of the times, AP and lateral alignment will come together. Worst case scenarios, you can use ender's nails to get into alignment, and then bone ends needs to be freshened. You have to get the bone ends freshened. Suppose if it is non-viable, then you have to have take a giggly saw. Don't use your oscillating saw. Oscillating saw, when you use, it will lot of smoke will come up, and then you can do some sort of necrosis. So giggly saw is actually good, because the moment you use a giggly saw, you will see that immediately it will cut faster, and then there won't be any area of necrosis, and then you will get a good surface or area. So what is important is you have to get a circumferential contact. For that, you have to have a that is a giggly saw. Get it, and then you make it into a nice shape, so that you, once you have a nice shape for you, then there will be a circumferential contact that you will establish. Both the AP, lateral, medial, posterior, everywhere you will get a good contact of the bone, and then plug in the intramedullary graft. You plug in the intramedullary graft, and then bring the bone ends closer. So you get the bone ends closer. Or if you have this facility of having a fibula or some sort of metatarsal as an allograft, they are good, because you can use it as an intramedullary strut graft, and then you can bring it together, and then you bring both of them together, and then place the plate. Use K-wires to get your alignment from proximal to distal, get your alignment. And then once you have all these placed correctly, and then fix on the one side where you want to fix, you can choose whichever direction you want to fix it up with. On the other side, you have to use the Muller's compression device, and then Muller's compression device on the other side. Once you are fixed on one side, then use the Muller's compression device and then tighten it, and then the bone ends will come closer and closer and closer, and you will have achieved a good compression at this fracture site. Once the compression is achieved, then you complete the fixation on the other side also, and then make sure that once the plate is applied, you have to decorticate it, and then once it is decorticated, you have to pack bone grafts on top of it. See, like this, once you decorticate and pack bone grafts, and then the bone grafts that you place on outer side must be after your decortication, that is shingling and osteoperiosteal petaling. These two terms you remember, and once you do that, pack all the way around, so medial, lateral and anterior, and then once you have it done, then that is the way you go about in all these non-unions. And then the solution that you have got is stability, contact, alignment and biology. And if you get it, everything will be done. So you will have all the aseptic non-unions, you would have got it right. I thank you all for listening to me for, I don't know how much time I took. Hopefully I get it right. Yeah. Thank you all.
Yeah. Thank you, Dina. That was a wonderful talk I've heard. Good that you have chosen a topic which was talked least in this webinars about the humerus non-union. Can you stop sharing your screen?
Yeah.
Yeah. Let's take any questions from the panelists first. Ramesh Babu, sir.
Excellent presentation, Dina.
Thank you, sir.
You have cleared all our doubts, and you also showed us how to handle the difficult problem. I've got few questions here.
Yes.
You mentioned about the rate of non-union in humerus, 5 to 10%. Is it after conservative treatment or is it after surgical treatment?
It is after, sir, various literatures I took, sir.
Okay.
It is including the operative as well as conservative management.
Both combined.
Actually, if you read Campbell, they say that 98% of the times conservative treatment will work well. So that is why the ratio comes from 2 to 10%.
Very good.
It is both for conservative as operative, sir. But operative non-unions in majority of the literature is higher, sir.
Okay. And you have been talking about cabs and other things. I
Yes,
just
sir.
want to know, is there the placement of the plate? Placement, does it decide? Because humerus, the tension side is the posterior side. And in most of the situation, what is recommended is to put the plate on the tension side. But whenever there is a flexure deformity, the tension plate becomes anterior. So they say you put on plate on the anterior side. I just want to know whether the placement of the plate also decide on the causation of union or non-union.
So majority of the times, the plate choice that you want to put, where the area that you want to put, mainly decided on the location of those fractures, non-union. Suppose if it is, say, for example, truly a mid shaft, you can place your plate anywhere you like, actually. Like you can put it on the lateral side, medial side, posterior side, and then you do all these, it will definitely be all right, sir. Whereas the common location that we choose is either lateral side or on the posterior side. So only in a fresh fracture scenario, it will be sometimes you might use on the medial side. Whereas suppose if the fracture non-union is extending more towards distal side, you can't put it on the lateral side. You will have to configure your plate, or you will have to slight bending of the plate. So those things you will have to do. It is cumbersome, so you may go wrong in those things. So best is the posterior surface, because it is a straight surface, flat surface, and the moment you put a plate, automatically your the anteroposterior direction of your alignment will immediately be sorted out. So posterior surface is the best surface for a non-union, I believe, because with over the period, with all the experience, the first choice would be to go into the posterior surface.
Thank you. Thank you, Dina.
Very nice collection of cases, Dr. Dheenadhayalan.
Thank you.
There is one question from my friend. He wants whether to put the plate anteriorly or posteriorly or laterally in middle third fractures.
Suppose if it is a fresh fracture, that's what I said. If it is a fresh fracture, whatever surface you choose at that right is a right location. All of them is a good surface in humerus to plate. There is no doubt about it. But in a non-union scenario, right, as I just now answered, I would go with the posterior surface because very simple. It is easier surface, simple surface, and radial nerve also you will see it and then protect it. So everything is sorted out. So there is no issue at all.
I completely agree, Dindal, that every time we face the non-union, we have to plate it from the backside. Not only because of the safety, because we have to see the radial nerve near naked eyes. And whenever I find a non-union, I primarily dissect the radial nerve from the top.
Yes.
Otherwise, it is very difficult to find the radial nerve. Actually, if we try to find the radial nerve at the fracture site or near to the fracture site, it is completely been haywire. It is better to find, it is a no small incision in non-union. It extends from my incision is from more or less from the acromion to the elbow.
There is one question. Sometimes we see some osteolytic area. Even the post-operative X-ray is good, maybe in the second month or third month. So when do you advise revision surgery in such cases?
Suppose if you see that previous say for example 6 weeks you have seen an X-ray, and third month you see a lysis around the fracture, that is a screw holes. That means it is if the fracture site is not yet healed, that means it is an impending failure case. So that is at least at this stage you can warn the patient, and then make sure first look for all the septic parameters. Make sure that there is no sepsis at this stage, because if there is a lysis around it, first thing you must look at is sepsis. So rule out the sepsis, and then you look for the fracture site. If it is showing some callus, probably yes, you can give your thought process and see that we can wait for some more time or see, because another X-ray also, if there is some more loosening, you should not wait. The first time you see a lysis, maybe you have to investigate for sepsis and then probably initiate treatment according to the diagnosis that you get.
Yes. There is a question, Dina. One case where you have shown augmentation, nail and plate together.
Yes.
Nail was not locked distally. Is it not required to interlock both the ends when you are using the combo technique or augmentation? This is Dr. Swapnil Kotadia from Sholapur.
See, nail is just as an intramedullary strut, whereas plate that comes off is only used as a derotation. So your screw, whether you use it or not, may not make much difference. So whereas maybe if you use it, it may be an additional stability, but the plate itself is sufficient, because once you use a plate, that itself is sufficient to give adequate stability for it.
Yes. There is a question from Dr. Gajanan Kulkarni from Aurangabad. How to save the radial nerve while approaching via posterior approach in already done posterior approach?
So every time you do a posterior approach, actually, as Samantha said, it always start from the top down approach. See, like you go and then you identify the two heads of the triceps and then come down between the raphe. You will always find it. There is no problem at all in every case, even though if it is operated from posterior approach, every time you go posterior approach, you can always identify it, provided you go through the two heads of the triceps. One of the best technique is you tap on the triceps. You go above and then tap on the triceps, and then you will immediately see that each of the head will constrict, and then immediately there will be buckling line that comes up, and you will put your finger in between and you start dissecting. Then you will get into that line, and then you can easily identify your radial nerve without any issues.
Yes, Dintal, I completely agree. And this is a very, very important trick of doing the non-union case. It is never a small incision. As I told, it is from the acromion to the point of the elbow. And the best thing is to dissect between the long head and a lateral head, because this is like the 2V. If you go in between the V at the top, you will immediately find the radial nerve. Yes. Otherwise, if you try to trace down the radial nerve from down to up, then you will be endangering the radial nerve 100%. But if you come from top to down, you will see the whole course, because there the radial nerve area the anatomy is completely been virgin.
Yes.
In complex non-unions, do you have experience of vascularized fibula graft?
I do have.
From Hubli.
I do have vascularized fibular graft, but I didn't want to put it because I wanted to bring this concept, that normal concept for every case that you have to do it. You have to get it. I do have a microvascular fibula case. I didn't want to bring it. I have done it. We are doing it here. So there is, But that is done
Yeah.
only in case where we have to resect too much of bone. Suppose if there is, you see, like one of the case that I showed where there was a deformity and ballooning effect was there in a large segment. Many times when there is a plate held for a long time, patient doesn't come to you very quickly and the erosion has taken place too much. And then if it is also a little bit of infection is suspected, then you resect long segment of bone and do a microvascular fibula. But in all other cases, you can get away with this technique that I have showed you.
Yes,
Yes.
another one thing another one caution is this ballooning effect. Whenever you see this sort of ballooning, what my friend he was showing, 50% time you have to be overcautious that probably you are not missing something infected, because these are low grade infections they are inside, and it is better to take care that when even if you do a plating, bone grafting, whatever method you do, I usually put some sort of antibiotic which is there. Most of the time I put that, because I have also sent one case to my friend Siva why it was the ballooning effect. I always put the antibiotic beads. Do you do that, Dina?
No, whenever I see it, my only indication to put an antibiotic cement would be like I have to see the pus. I have to see that previously the patient should have had fever and then they should have had some sort of proven infection. Then only I go for it. Otherwise, in humerus, moment you open it and you see that, as I showed, that there is a blackish discoloration, some sort of fluid that comes out. You nicely debride it, get a good stability part of it, and even you send it for culture sensitivity. Later on, if it grows some Klebsiella or protease, you manage the antibiotic part of it. Generally, it settles down, because humerus is one where it is a viable bone. It is actually having a good blood supply. So you don't have to be worried. So you have to completely give all these parameters, you get it right, you will be all right.
Yeah. Another reason is there is instability of fixation, especially there is a loose nail. When the bone moves, that erode on either side. So ballooning happens even in unstable fixation, like lower end when you have applied a plate or even the nail is loose. So there is one question uh, again by Dr. Bhaskar Rao from Hubli. He asked to know, do you use nerve stimulators in repeated surgeries?
Nerve stimulator, why we should use, I don't know, but we use nerve stimulator only when there is a proven injury or proven nerve damage that has taken place, and we are correcting those. But regularly, I don't use. There is no need for it. If your dissection is good, if you can identify the radial nerve without any issue, then why you should need a nerve stimulator? Probably Bhaskar Rao wants to know, suppose if there is a lot of scarring, you are having a difficulty to find out. Yes, definitely if you have the nerve stimulator, you can use.
Okay. Dr. Dinesh Shetty from Kundapur wants to know role of interfragmentary screws in oblique fractures. If it is short oblique, whether to use or not.
Short oblique means you have to tell whether it is less than 30 degrees or more than 30 degrees. So, because very small short oblique and all, you don't need an interfragmentary. Whereas if it is a long oblique, then only it is possible to put a interfragmentary. If it is very short oblique, it is actually the way you put a plate. You have to get the right way. You have to. It is all like in EVO basic course we teach.
Acute and obtuse angle.
Yeah, obtuse angle areas you have to.
Yes.
Yes, Vidisha, you have a question, I think. Yeah.
How to achieve compression in osteoporotic fracture, because Muller's device won't work there. So do you advocate Elizarov assisted or external fixator assisted compression in osteoporotic non-unions?
I have done a lot of these patients, and so far I have not experienced or where Muller's device will cut through or something like that. I don't see any of those situations. But we have done many cases with osteoporosis. I have not experienced this issue. Maybe if you want to use, you can use all those. I don't worry about it. But here you see it is very simple technique. And then this device is a wonderful device. And then it won't cut through and all. Right? Because if you put your screw and then hold it and then you are going to compress it. And then it is not like you are compressing to your pressure. You are compressing it to the requirement of the bone. It is, you have to see, like physically you are achieved contact already. See, when you are putting a plate and then you have already got the contact with your physical compression. And beyond that, you are going to use a Muller's compression device. So probably your 5 or 6 threads will bring you at least 5 millimeters of compression. For that, I don't think any osteoporotic bone will fall apart.
Yes, Didi, I completely agree. We do have that Muller device in our AO set, but basically we do teach them in the AO meetings. But probably most of the people in the actual scenario, they are afraid of doing this because of the probably they have to extend the exposure. But this Muller device is an magic.
No, it is good. In any of the non-union, upper limb, lower limb, it is always good to use it. There are a lot of Indianized versions. So a lot of people can use it.
Yeah, that's correct. There is a complimentary message from Dr. Subhash Haldar from Halifax. Very good presentation explaining how to fix complex non-union. So then there is a question from Dr. Swapnil Kotadia from Sholapur. Any role of bone marrow injection before opening the fracture?
Bone marrow injection with what?
I think
Any
from
role,
the
either the platelet or bone marrow aspiration, if you think that the fracture is going for some delayed union or
Didi, I think
I will show one case. I have got one case we'll discuss at that time. Vidisha, will you start with the presentation? I am sharing the screen. This case, first one is by Vidisha.
So this wedge type of fracture. So any open, okay, this was fixed with MIPO technique. And do you think this fixation is adequate? Dr. Swarendu?
Yes. Some people now we argue like when we do the MIPO, probably how many screws on the top, how many screws on the right, downstairs. But that day I told that probably 3 on the top, 3 on the down. But still, there are papers are coming. You can go ahead with your 2 screws on the top and 2 screws on the bottom. So people they are doing this with this 2 screw down and upstairs and downstairs. Sometimes it heals.
Dr. Ramesh,
Vidisha, what is this? Can you see this?
Yes.
Is it a drill hole, additional drill hole, or it will be a space?
Tried fixate or assisted?
Fixator assisted,
Okay.
because this is the hole for this hinge pin, because try to reduce the fracture to the axis.
Yeah.
Okay, fine. I normally use a Endas Taylor at TENS and
manual only. It was initially tried with fixator.
Okay.
So Dr. Ramesh Babu?
You have to unmute, Ramesh.
There seems to be an alignment problem. I think the medullary canal is not matching. So I think this is an alignment problem and it may fail. And I will also prefer to add one more screw, number of screws or less, according to me. I feel it may fail.
Dr. Dheenadhayalan?
No, it is, see, like the 2 screws or 3 screws, this controversy is there, but 2 screws also sufficient. But however, it is not the question of only screws, but it is the question of how stable that you have given it. Because now you see there is a length of the plate that you have left off is too far outside. So maybe that there is a lot of instability at the fracture site, because there may be some alignment because of the alignment issue. So maybe that you could have got one screw little closer to the fracture site will give a little bit additional stability, and the elasticity would come down. So that may be an issue. But you see this, when you do these fractures, only thing I always look at is the contact at this fracture site. When you do all this MIPO, and if your assistant was holding with traction and you put, it is different. Whereas at some stage you should have asked for somebody to push it and then give a pressure. So I don't know at what stage you gave it. So
initially the conventional screw was tried in the lower third hole, but it was through the cortex. So eventually it was removed and only 2 screws were fixed.
Okay.
The lower fragment.
This is another one comment from my side. If you see the second screw from the downstairs, probably it is just going through the cortex to cortex because the plate is angulated. That's why probably I think it is a very, very flimsy sort of, yes, that screw. Yes, that screw. Probably it is a very, very flimsy, and I completely agree with DD that if you give another one screw, probably this elasticity of the plate will reduce and this will help in union.
Your plate could have gone little lower than upper.
So now
it is too elastic.
Anyway, my tips are what DD said, putting 2 KYs above and below, then it gets the alignment. That's one way. Second way is apply the second screw, only not the last screw, apply the second screw. Then you still have some place to manipulate and get the alignment. Then finally you have to put the last screw. This is another way of getting a better reduction.
the wire was put, K wire was put to hold both the fragments and it broke.
Yeah.
The wire in the lower fragment, it broke.
Yes, another its K wire is visible. They are in between the 2 screws.
So
Yeah.
this is 8-month follow.
Yes,
Now,
1 and 2.
yeah.
Is there any pain?
Patient had some minimal pain at fracture site.
Yeah. I think there are not adequate signs of healing. So we have to interfere.
Okay.
I think because this is not going to heal.
Dr.
I think this is where we can try either only bone marrow injection or probably it's holding well.
8 months have passed, and then screws are all holding very well.
Yeah.
And then you can see
Yeah.
that only the non-union, but it is the patient pain is severe, and I will still go ahead and think it is a non-union and go and operate.
Yes.
Whereas if it is pain is not there and you want to wait, but many times this will fail because if 8 months is over, then sometimes a plate also
Yeah.
will.
There is some gap also is seen here. Yeah.
Yeah, on the,
Okay, shall I proceed?
on the medial side.
Sure. So now 1.5 years. So there is
Now
some
it is become.
osteolysis.
Yeah.
Now it is evident that this screw, the plate is pulling apart.
Yeah. Yeah.
Now there is no question. We have to go ahead, and whatever DD has taught us, the cabs, we have to do it.
So ultimately, patient agreed for surgery after 2 years.
Oh.
So revision surgery was done after 2 years. So amongst my 63 cases of MIPO, this is a single case of non-union I had. Among 63 cases with 2 screws or 3 screws, whatever. In few cases, it was seated eccentrically, but this patient failed to unite. So after bone grafting and compression plating, ultimately it united.
Do you think in the initial phase itself, brace would have helped?
Probably, maybe.
Okay.
He was given immediate physiotherapy as per our protocol. The second day, he started mobilizing shoulder and elbow. And so the follow-up, 1 year follow-up. Dr. Shivshankar, please share the next slide.
No, I just have a question here.
Yeah.
You put a plate anteriorly, isn't it?
Yes.
We have been just discussing that posterior plating is superior in
No, the primary plate was also on the front side, no? So he has revised that on the front side.
Same incision plating was done.
It was the MIPO one, so it was the anterior incision.
Anterior, yeah.
So C has to go from the front.
Okay.
Any comments? Yeah. So as Dr. DD said, gap is not tolerated at fracture site, even with MIPO.
No, I think Vidisha, the main thing is not the question of the how much gap, it should be in contact. If you leave too much of gap in transverse fracture or the short oblique or the small segment fracture, because these are all high energy injury, this is not going to, even with the MIPO, is not going to unite. But if it is a comminuted fracture, sort of long spiral, whatever, the lower force is there, then probably with the MIPO it is going to unite.
Another case, little bit straightforward. 11-year-old operated humerus presented with this broken implant. So now whether to go anteriorly or posteriorly? Dr. Ramesh Babu?
I will go posterior.
Okay. Any difference of opinion?
You know, Bidise, that I will go to, I told you that I will always go from the back side, never from the front, unless it is done from the front primarily. Posterior is 100% for me.
Dr. Shiv Shankar?
Yes, posterior in this area. If it is slightly higher up, I'll go anterolaterally.
Okay. So revision was done with bone grafting, plating. Again, the plating was done posteriorly. And next follow-up. Union.
Yeah.
And this is the
Function. Yes.
Yes, nice one.
Okay. Yeah. This is one case. It was operated in my setup only, but I was not involved in this surgery. I was not in Solapur on that day. This is day 1 X-ray. Swarnendu?
Yes, this is obvious.
Yeah.
It is, unless the surgeon is too lucky, this is not going to ignite.
Correct. Vidisha?
same here. Two
Yes.
screws could have given more stability. 2 screws proximally to distally
Yes.
and
Correct.
a little bit more compression.
Yes. Correct. Ramesh Babu?
I also agree. Probably whenever I see some inadequate fixation, I will add a brace.
Okay. Yes. DD, your final answer.
No, actually it is a well done nailing only, because when you do nailing, this is what you get anyway because of the communition.
Yeah.
But question is, when we see, like as Vidisha said, maybe another screw we could have added both proximally and distally. That is one option, because especially distally, because it is fracture is more towards the distal side. Otherwise, there is no issue. So we'll have to wait and see how it heals. So now there is a
1 month. There is, at 1 month there is much more resorption.
Yeah.
This is 2 months.
This is what happens. I have seen like many of the nailings. Initially, though it appears as though it is in contact, moment you see a gap, especially those with associated communication, they end up with gap non-union.
Yes. Unfortunately, upper limb, we cannot do this weight bearing and allow this to collapse. And the humerus nail don't have the option of dynamization also.
But
unlike
now,
the lower limb nails.
now the humerus nail have come with compression. We can achieve good compression.
Only compression is there, but if it cannot allow dynamization, means you cannot ask them to walk on hand to allow collapse.
There is no question of dynamism. Yeah, you can compress. Yeah.
Yes. Okay, Swarnendu, 4 months. The patient has come to me now. What I should do? Or come to you?
Pain there or yes or no?
Not much pain. Only the X-ray I am not happy. Clinically, patient is doing all activities.
Still, you can wait and watch.
Yeah.
Yes.
Pain is
Ramesh?
the deciding factor.
Pain is the deciding factor. He is telling that there is no pain and is not much pain. If the patient is not, there is no tenderness at the fracture side, I'll wait.
Okay.
So
you have showed
you have showed what you have done, but before going for that, I will opt for a CT scan.
Yes, CT
to
scan.
Assess,
okay.
To assess for the talus.
Okay. So what I did was I got a fresh frozen plasma and injected at the fracture site. This is at 5 months. I did this injection.
PRP.
And he came only after 2 years. He came for implant removal. Actually, I said I was not comfortable to remove this implant because that's looks like a still hourglass contraction, and if I remove the implant, it might break. So he has not come back again. He had come in October 2018. He has not come back again. There is a
When he was
case.
not,
Yes.
Did he?
Yeah. Did he?
when he was not having pain, why did you choose
Yes.
for plasma-rich plasma?
There was too much of gap. I was not happy with this. So I wanted to do something not major like bone grafting or not leave line also. So anyway, I have done in few cases and it has helped me. This is Dr. Milind Joshi's case. This was treated initially with V-nail and K-wires in this fashion. And since the medullary canal was narrow, the distal fragment was shattered and there was too much of gap at the site, and all the nails were also proud. This was treated with plating and bone grafting. You can see bone grafting has been added, but very narrow medullary canal. Then subsequent pictures showing union. So getting gap filled, aligned properly. So that's very, very important. That's what the point we had to take. Then we have a presentation sent by Dr. Prakashappa, professor and head of the department at Sanjay Gandhi Medical College in Bangalore. This is a case of 45-year-old male patient operated for humerus shaft fracture 8 to 10 months back elsewhere and presented with non-union. How to proceed this? Yes, Ramesh Babu sir.
There is, we have to follow the same rules as Deena has mentioned. First and foremost,
Yes.
rule out any infection, and if there are no
Yes.
infection, then we have to go ahead and do the posterior side, remove the implant, and identify the medullary canal. And you can, because the almost lateral side, it is all eroded. There is not much of bone. So you need intramedullary strut graft, and in addition, achieve good contact, compression, and alignment, and improve stability with the plate.
Yes. Anything else anybody wants to add? Yes,
Yes,
because Ramesh Babu has said everything.
Yes, Siva, I think
Yeah.
thing is that primarily this plate was done through delta pectoral, Henry sort of
Yes.
incision. So I think
Correct.
you have to go again with the Henry, extended Henry.
You can go from the delta pectoral approach extended. Now
That
it's not
that
much of it
I told
because
them
10 months back.
no, I
Yeah.
told that this is gone through the Henry. That's why you have to go with the
Yes.
delta pectoral and along with the Henry, like you, the whole Henry approach, like.
Yes.
The lateral side is almost no bone there. Lateral cortex
Yeah.
is eroded.
So this,
Correct. Yes.
this is one of the location you can see, like the canal is wide and then it is going towards the proximal side. If you get what Ramesh Babu sir said, like if you get intramedullary strut, then it will align it correctly. So
Yes.
only after alignment you must put a plate.
Yeah, that has been done. Implants have been removed. Atrophic non-union site 3.5 centimeter, excise intramedullary fibula graft, corticocancellous graft, and pilose has been done. Any comments, Ramesh Babu sir?
I think again the plate placement is not proper.
Yes.
Rotation.
Rotation.
No,
Or
no,
even they eccentrically placed.
no, Siva, the problem is that we don't have the classic rotated long Philos plate.
Yeah, pilose plate. Yeah, correct.
Every time you want to give this plate, it has to be look like this only. Whatever whoever
Yes.
does the surgery, the plate will be bit eccentric or at the downside.
No. This extension of the arm, which can be seen, the humerus, could have been little flexed. So anyway, this is only one view.
There is broken drill bit inside,
Yeah.
Yes.
and this plate is applied laterally.
Yes.
And
This is
what
correct
about
view.
the radial nerve?
Radial nerve, there is no comment. This is the presentation I have received.
But the main bone has not been compressed, though they have put the intramedullary strut. So the main bone should be nicely compressed.
Okay, so you expect some problem to happen here.
Yeah, because you cannot just depend on intramedullary strut like that. You have to have the native bone to be in contact. Then your intramedullary strut
Yes, yeah.
function.
Yeah, this it should have been strut should have been, yeah. Okay, this is 3 months follow-up, 6 months follow-up. After 6 months, patient had a fall and sustained injury. This is how the patient has come again now.
So that means it was not united.
Yeah, that's what, as Dr. Deendayal said, there was not much of contact, and all the stress has been taken by the plate and
And
whatever
the
the
graft.
fibula which was there
On the
interposed.
graft.
Yes. How you will treat?
Sir,
Swarnendu.
I want to ask one question to DD first, then I will come to this X-ray. Suppose the
Yes.
DD feeling that once you put the your intramedullary fibula, you cannot make contact of this bone fragment to the other. How you do that, DD?
No, because it's a wide, you see, you have to choose intramedullary strut graft only in a canal that is wide.
Yeah.
So when you have a wide canal, it will be loose. The intramedullary strut will be loose. You can always collapse your main native bone.
Yeah. Because the thing is that, but still, you see, whenever it goes into the distal fragment, it's very difficult to compress here even, because this is probably the narrowest canal here.
But in
Yes.
this fracture, like initially itself, I saw, no, it was wide enough to have a strut graft. So it is also more proximal.
Yeah.
Unless it is very distal, you may end up with such problem. Whereas when it is proximal, you always will be able to collapse it.
Yeah, but in the middle third, do you feel that, DD?
Yes, you can still do this here.
Okay. So now the question is that we have to take out, obviously, you have to rule out these classic things like rule out infection, as it is already been done twice, remove everything and redo, following the principle like compress. I think the main idea of treating the non-union in humerus or whatever you do, the first motto is the compression. If you can't compress the fracture, whatever graft, how many graft, whatever mode you do, it is not going to unite.
Yes. Okay. This has been done now. Compression, bone grafting, refixation with LCP, corticocancellous bone grafting. Yes, Swarnendu?
Looks like they have shortened the bone also, isn't it?
Yes.
Hmm.
Swarnendu, you are muted.
I think they have.
Swarnendu,
Yes. No.
Yeah.
Now I think it is there. Now they have taken out that part, atrophic part. They have, I think they have got to the bleeding bone, and they have compressed the fracture.
Yes.
So and done copious bone grafting. So I think this can unite now.
Now the alignment also looks better. Alignment is better.
Now I think the surgeon should be lucky,
Yes.
and the patient should be lucky, and this should unite.
Yes. Anyway, I don't have too much follow-up of that. Another case, again, very badly initially treated. They have done the total excision of almost 5 centimeters of bone has been excised, and bone grafting has been added. This is just 6 weeks picture we have, so we'll not discuss further. There is a question to DD from Dr. Sai Prashant. How to achieve compression with nailing alone? That's the question.
No, nailing alone means there is newer implants like AO system has come out with nail where they from the top, when they put a compression nut, it can go on to hold on to the screw and then compress it. That's what in the tibia and all we are doing, no? Same technique has come up in the humerus.
It is there in the AO system since long. Since long it is there.
Yeah.
Yes.
That system
There
we
is
can
a
use to compress it.
yes. There is a question from him only, Dr. Sai Prashant. Do you use teriparatide or bisphosphonates in non-union for humerus?
Sai Prashant was my student. He is asking me questions like teriparatide.
Okay.
Teriparatide I don't use much because only in osteoporosis and all we use, but not in all non-unions.
Yes. Okay. This is a next case I'm presenting. I was doing a lot of humerus nailing with retrograde L wires, lambda wires, before the interlocking nails came in the market. And I have seen quite number of non-union also, which was there. But once the Elizero came into the picture, in the 90s, I started putting one ring above and one ring below, and I compressed those fractures, and majority of them united. Unfortunately, I don't have much slides to share because I lost all my digital pictures due to some virus, Trojan virus, sometime in 2005. Here is an interlocking nailing done. Only nail was used, but no interlocking was done. So this patient came to me with again non-union. Again, I compressed in a similar fashion, but he has never come back to me. So he said that he is perfectly all right. That's why he got the fixator removed elsewhere. Any comments upon this type of? Let me ask Vidisha because she does a lot of.
No, I'm using Ilizaro in very few patients, that too infected non-unions. With the advent of cement, antibiotic impregnated cement block, I'm using it more quite often than Ilizaro.
Because
Previously,
here
I used to compress
interlocking. No,
with spring.
interlocking nail, I cannot achieve compression. So because I cannot achieve compression properly, instead of using a interlocking bolt, I'm using an external fixator and trying to compress and get the union. Any comments, Didi?
No, it is. See, like it is. Principle is that compression. Humerus is one
Yes.
bone which will respond
Correct.
immediately if you compress it.
Yes. This girl had a compound fracture, and she had, this was actually had operated with Dr. Matre from Panvel. External fixator was applied, then plating was done, so many things was done. And what I did was there was no infection when I went and operated it in Panvel. So interlocking nail again with a fixator, I gave to that patient, and that patient also did well. This is another similar patient which I had treated, but I don't have the initial pictures. Again, I had treated her with the external fixator, Elizaro. So you can see that one of the screw is there. Earlier plating was done, it had failed. So again, nailing plus Elizaro also works basically to get some compression, especially in very distal cases like this. See, very distal fracture where you cannot get the interlocking bolt into that area. So I have used in few cases. This is an interesting case which was operated not very well initially. So it was bound to fail, and second surgery was done again. That also didn't work well. This is the time the patient has come to me. Ramesh Babu sir.
I think there is distraction at the fracture site, and
Yes.
the fracture has not united, and we have to revise following all the principles which have been explained.
Yes. Okay, Swarnendu, I think he's busy on mobile.
No. I am seeing that case. So
Yes.
this problem is already the implant is loose. There is a gap, and you have to all take out, and shorten the
Yes.
area, and you have to compress and do grafting. I will shorten the
Okay. Vidisha. Okay. Vidisha,
Is there
you
any
agree with that?
infection associated?
No. Absolutely fine. No
Aseptic.
infection.
Then revision with compression plating with lot of bone grafting.
Okay. Yes, Didi, final answer.
Yeah,
Agreed.
same thing, agreed, because
Okay.
it's going to
Yes.
fail, looks like. So,
Okay. What I did was a nail with augmentation plate.
yeah.
So I used a interlocking nail. Then by the side of the nail, I have done the plating. Actually, there was a question earlier. You have not done the interlocking. Normally, when I do a nail with augmentation plate, I also never do interlocking on both the sides because it will not allow collapse if it is required when you
Yes.
are applying the plate. And I normally use a wave plate so that you can put the graft also underneath that. This is just at around 4 months time. This is at 9 months. Beautiful consolidation had happened in that patient and did the function in the same patient. This case I operated with Dr. Manmat Raut. Thanks to him for sending these pictures. Another case, multiple LYs, TENS have been done in this patient. Who wants to take this?
Again, Siva, you have to take all the implants out and freshen
Yes.
this is atrophic non-union. You have to freshen the ends and compress it properly, and compression plating and bone grafting.
Okay. Which side? Posterior, anterolateral,
Here you
plating
can
where?
here you can go whatever side, but you know that I'll be going from the back side.
Okay. Ramesh Babu?
I will do the same. I always go for
Okay.
posterior approach.
Yes. Okay, Vidisha?
I will go from anterior side for this case.
Okay. So you are there with me. I also normally go anterolaterally at this level. Didi?
No, that's what I told beginning also. No, mid shaft, it doesn't
Yes.
matter, anterolateral or posterior.
Correct. Yes. Okay. This was treated with removal of the tens and re-nailing with the interlocking nailing, and the interfragmented screw has been done.
No, Siva, this is not going to unite that way unless the surgeon and patient both are lucky.
Okay.
There is distraction
Yes,
at fracture
Ramesh?
site.
Because this is not the
Yes.
principle. Because this is not the principle of doing it.
There is
Yes, correct.
distraction
It's
at the
bound to
fracture
fail.
site.
Yes, it is bound to fail.
It is
So
bound
this
to.
was what I was telling. Ballooning. See, if the nail is loose and the bone is moving, so this ballooning happens, especially
This
this
is
is more common in humerus.
Siva, this
Yes,
is the windshield wiper effect.
correct. Yes. So how you treat Swaranendu now? This patient has come to you now. No infection.
No. Obviously, you are definitely talking of the aseptic non-union. So everything you take out, and I will just not only put one plate, rather I will try to put one plate and 3.5 the recon, whatever you have shown us, just to give more stability and bone graft, and go up to the end of the humerus.
Okay.
Lower,
Ramesh
lower.
Babu?
Yeah,
Yeah.
I will go for both intramedullary and extramedullary plating. Intramedullary Ender's nail, what DD has shown, or I
Yes.
have to consider putting first thing I will shorten the bone and make sure
Yes.
there is raw surfaces and there will be contact all around. That will be my first principle. Then I will
Yes.
use achieve compression. The intramedullary rod will achieve the alignment, and I will use a extramedullary plate to achieve compression. And
Okay.
bone grafting also I will add.
Yes. Vidisha, any change?
Same thing. I will also go for
Okay.
dual plating, laterally extraarticular plate and medially locking recon plate with
Okay.
bone grafting.
DD, yes. DD, I don't have access to intramedullary bone graft like what you have got metacarpals you use. I don't have the access to that. How I should go?
But you have a tricortical bone graft you can take, iliac crest graft, you can take tricortical bit, and then that you
Yes.
can use it, shape it, and you can use it as an intramedullary graft.
Yes. Okay. So actually this was the time I came to the picture, this patient. So already everything was walking, and you can see that it was so loose and the bone was also eaten, and the patient was unable to move the uh, elbow as well as shoulder. So the distal humerus, because of the screw, you can see that it had eaten up the bone so much. And whatever the graft I had taken, I had planned to put it both is this place at the non-union site, but I ended up using at the non-union site only. I didn't put any graft here. There was only one screw which was going beyond this, but I have used 10 cortex above and 8 cortex below, and this part was there was no bone, so that's why I couldn't put anything. Now, any comment at this stage by anybody?
No, as I told you, Siva, that it has to be like you done the fixation, but I will rather do it double plating.
Yes. Yeah. Your point well taken.
These are the
Okay.
cases you can also think of Ender's nail.
Yes.
Yes, because of the both stability of from both intramedullary, because it needs absolute stability.
Correct. Correct. Yes. So non-union requires absolute stability. This is at 3.5 months. This is at 6 months. Luckily, the everything went off very well, and this is at 6 months follow-up. You can see that the patient is able to do the function. Yes, Swarnendu, you have got a case. I think you can share
So
your
now
screen.
I think everybody has done with their cases, no, Siva?
Yeah, yes.
Okay. So Didi, we have learned many things from you today. Just the revision of ideas, and your talk was, as you, it is too great. It doesn't need any mention. Whenever we listen to you, we know that you are going to teach us something.
Thank you.
And we learn the principles.
Yes.
Yeah, we learned the principle. That is the most important thing. Didi, this is a case for you. Is it visible, Siva?
Yeah.
Yeah, yes.
This is 45 years male patient, came in, probably you can see that October 2018, left side fracture. He came with that. And this limb is post polio. And this nail was driven. Probably he is telling that it is like in his childhood, he could not recollect. Are you going to do something with this, Didi?
See, right now, is it paralytic?
Yeah. This is the PPP post polio.
He is using it for what type of purpose? Is he like wheelchair bound, or how does he?
He's walking. This is the only the left upper limb is involved, and he came with that. And there is a but he told that I am having this since childhood. I don't remember. I don't have any pain, but this is the picture. Can you do something for me?
But he is lucky because if 45-year-old now means probably 20 years he may be having this. He is
Yes,
lucky.
more than 20 years. Yeah.
Anytime it can break also. So better to think that we can revise it. If he has got pain or something like, if he is not having pain, better we wait till it breaks and then he comes.
Okay, but I told that when he came, but after some time, probably as we apprehend, this is the next picture. Did he?
So it is broken on top.
Yeah. The actual area which we are discussing, that is now as such, but now it has gone like this.
Yeah, so it is more proximal now. It is, we definitely need to remove this. So we'll have to probably cut the, or sometimes what you can also do is through the fracture site, go in and then cut the nail and then remove it off. And you proximal fixation you can do with plate. And then if you are not able to remove this distal wire, you can also just think of mild augmentation with bone
Plate.
graft and then leave it, or you can just leave it till sort out only the proximal fragment.
Yeah, because I was really worried because he could not recollect when it was done. So I told them that probably I won't be able to remove that nail. Only I am now dealing with this your fresh fracture. Siba, am I right?
Yes.
Vidisa, any comment?
What was the shoulder function? 0?
Oh,
Great.
he was like 0 because you see, he was just holding the limb. Somehow he was just sort of jerky movement around the shoulder. So he was using.
Was there any shoulder pain?
No. Now, before this fracture, he was moving. There was no pain. Before this fracture, he was not any problem around the shoulder. Only because of your muscle power loss, he was just using with the jerky sort of movement and holding the limb with the other hand to take it forward and all this way. Okay.
No, even if it is paralytic, many times it is, if the skeleton is kept straight, it will be all right, because
yes,
if it is paralytic, majority of the times you will see like when he is walking, he will have a sulcus sign, everything may be present when he is walking. But now with it is broken and completely off like this, then the complete area will be very awkward and then deformity will be
awkward
severe.
and painful. Now it is not. Now it is painful,
Yeah.
and he has come to with that. Ramesh Babu sir.
I think once you address the proximal fracture, the middle third fracture is going to show him a problem. So it will become unstable. So I feel we have to tackle both.
Okay, but thing is that okay. So can I go ahead, Siva?
Yeah.
Yes.
So this was the CT scan, as we probably want to see the fracture, the upstairs proper way. There is a 3D just for the, but probably from the X-ray we can apprehend what was there, and there was gap.
Okay.
Obviously, it was in the X-ray. I told the patient probably I will try to remove that nail inside, but I don't know whether most likely I won't be succeeding to remove that. as because it is more than 20 years. So I went ahead as DD read my mind. So after 1 hour of trying and cutting through the fracture, I could not remove that nail inside. DD.
Yeah, this is what I thought, because if it is sustained for 20 years, then it would be a jammed nail and it is working for him. So I think that is the reason I said we may have to cut the nail up and then do only the proximal fixation.
Yeah, because I could not remove that. I tried, but I thought, because if I try to remove it, then in the same sitting I have to do something with the shaft. So I kept it like that because I don't want it to make it a much bigger surgery. So this was at the end, I could fix it, keeping that nail cut over there and fix it fixed with the proximal plate. So according to DD, your plan, I went ahead.
Yeah, that's the right one.
Oh, this is the other case. Sorry, I have sent the video to, after 2 years of follow-up, I have sent the video to Siva. Probably he will be able to, if he is there, he can show that video after 2 years. Like most likely,
Okay,
like you.
I've not downloaded it. I'll just
Okay, no problem.
try to download. You can discuss some case till that time.
Okay.
Yes.
Any question you can take now? Just I am stop the slides here now.
Yes. Any question you can, if you want to take, please take now.
Shiva sir, like,
Yes.
do you do, like, you many times we consider you as the nailer of the India. So in a non-union scenario, what will be the
Yes.
percentage of times you would have got success with nailing in a non-union?
Nailing alone, the percentage will be less. So you have to use an augmentation plate or an external fixator. Then only you will get.
That is
better
what I
result.
want.
So,
That is what I want to say, because in Humerus, nailing alone may not be successful, but nail with augmentation plate will be successful.
correct. Okay, I'll share the video of where is that? Varanasi. Is it coming?
Oh, I think yes, your screen is there, Siva.
Okay,
Your
I
screen is
think.
there with all the photographs, whatever in the beginning you showed us, but
Okay, yeah.
probably I think DD, you can summarize what are the basic message
Okay,
you
no, I have got one more case to show. Just now, after you showed that case, I thought let me discuss this case because we have the presence of people who will help me in this case. This is a 28-year lady with polio. How to proceed? Yes, Vidisha?
I will do anterior bridge plating if this is a fresh fracture.
Okay, fresh fracture.
Bridge plating.
Yes, anybody? Yes, anybody else has a different opinion?
It is narrow canal. Anyway, poliomyelitis, you should never think of any nailing and things like that. So it's a narrow canal, and it will work. It will heal with either bridge plating or regular conventional plate. If you do it very well, it will heal well, no problem.
Yes. Okay. So what I did was I used this is 3.3 millimeter K wire. Actually, it's not. I aligned it because sometime I used them, and since it was fixing well, I used a bridge plate over that. So this is how it was treated, and because it was giving definitely additional stability and the bone was so thin, I thought of leaving that back. Normally, I take them out once I finish my anterior bridge plate. Many of the time I take this out, but here in this case, I left that bending that tip. I left that in that anyway. Patient was not having any shoulder movements because it was a flyer limb. This is a recent picture showing nice consolidation. And okay, let me check my mobile before I say bye-bye to everybody. If there are any questions which have appeared in the last 5 minutes. Okay, there are no new questions. Okay, It was really excellent, Dr. Dheenadhayalan, to listen to you once again. And you people are doing really great job in treating so many similar cases and giving some guidelines to all of us to follow. The Ganga Hospital score has become world known only because of the number of cases you have got. And because of that, you can also come out with some guidelines. And we really look forward to you and your institution to give such guidelines for almost all the fractures. That will be my request during this webinar, so that if some white papers come from you and if we have some guidelines, then we can definitely use it as a basic pattern or template on which we can still work upon the further. I thank you for the time spent and the wonderful preparation you had done to make this webinar very useful. I'm getting a lot of congratulatory messages. I didn't take them intentionally, except Dr. Aldars. Thank you, Dr. Ramesh Babu, Dr. Vidisha Kulkarni, and Dr. Swarnendu for taking off your time from your busy schedule and being part of this wonderful webinar. I thank Dr. Ashok Sham and Neeraj Bijlani from Ortho TV for making this wonderful platform available to all of us. Thank you very much. And tomorrow we have got a Ortho Excellence Series webinar by Dr. Jayant Sampath from Bangalore. He'll be talking about what he has learned in 2 decades over in treating supracondylar fractures. He is a pediatric orthopedic surgeon from Bangalore. He'll be sharing his experience, what he has gained in the last two decades, and what new have come in this treating these fractures. He will be discussing. See you tomorrow at 5 o'clock. Thank you very much.
Thank you, sir.
Thank you, Shiva, and all the faculties for the excellent pearls, wisdom pearls. Thank you, Dheenadhayalan sir. Thank you, Ashok and Neeraj. Bye.
Thank you. Thank you very much.
Thank you.
It was
Bye-bye.
excellent.
Thank you.
Excellent. Congratulations, President Alexa. You are doing a great job during the pandemic.
No, this
We are
is
all
still
enjoying.
online. We have to exit. But
Thank
we are
you,
still
thank
online.
Thank
We
you.
have to. You
Thank
have
you
to
very
exit.
much.
All of you.
Thank you, Deena. Thank you.
Thank you.
Samantha.
Thank you.
Thank you, Vidisha. Thank you, sir.
Ramesh
Thank
Babu
you.
sir. Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye. Bye.
After you leave, I will be the last person to exit. Yeah. Yes. Thank you.
Thank you, sir.
Bye-bye.
Thank you.
Thank you. Thank you. Yes.